Thanks so much, Jeff. And it's a real pleasure to be able to introduce and moderate this discussion between three really incredible panelists. This comes out of a project that is known as the Bridges Project. This stands for the Center for Bridging Infectious Disease, Genomics, and Society. And like so many important projects in the field of bioethics, stems from these concerns known as ELSI concerns, right? Ethical, legal, and social implications. And a substantial focus of a lot of important bioethical work, over the past half century or so, has been looking at emerging new technologies and trying to understand to what extent do these emerging new technologies produce new social problems, new ethical problems, new legal problems that need to be anticipated or at least framed in such a way as these technologies are being incorporated. There's almost a point in which to think of them afterwards is too late once practice has sedimented. And yet, in order to try and think about the emerging, the ethical, legal, and social consequences of emerging technologies before they've even really come into existence, we're left in the province of history. And so I myself am a historian of medicine. I'm also a practicing internist. I see patients at the East Baltimore Medical Center. I'm very fortunate here at Johns Hopkins, not only to direct the Department of History of Medicine here, and we're not the only medical school with the full Department of History inside of it, but we feel a very important responsibility of bringing historical analysis to present day questions in biomedicine and public health, but also to direct a Center for Medical Humanities and Social Medicine, which really has its goal bringing together interdisciplinary conversations in this field. And both the Department of History of Medicine and the Center for Medical Humanities and Social Medicine are very active in these bridges discussions. And this kind of discussion that we're having tonight, which is really how we bring historical analysis to bear on day concerns of emerging technologies at the intersection of genomics and infectious disease, in which we have two historians and a philosopher to collectively discuss the important epistemological, ethical, legal, social questions that are emerging in this space, is exactly the kind of conversation that we're designed to put together. So I'd like to introduce the panelists. Robin Scheffler, who will be speaking first, is an associate professor in Science, Technology, and Society program at the Massachusetts Institute of Technology. Dr. Scheffler is a historian of the modern biological and biomedical sciences and their intersections with developments in American history. And he's working on his first book is a project that followed the history of cancer virus research in the 20th century, from legislature to laboratory, documenting origins and impact on the modern biological sciences. But his more recent project has been focusing on the development of the biotech industry, which has been happening, unfurling and dramatically transforming all of the area around Kendall Square, where Massachusetts Institute of Technology is. And so Professor Scheffler is in a particularly useful position to try and think about this intersection about genomics and infectious disease, both in his previous work and in his current work. Our second speaker, Professor Amy Fairchild, is the Dean of the College of Public Health at The Ohio State University, and also the Department of Health Services Management and Policy. And Dr. Fairchild is a historian who has worked for some time at the intersection of history, public health ethics, and public health policy and politics. And her work has really been foundational to the field of public health ethics as a distinct area from bioethics, individually focused bioethics or human rights. And she had a substantial amount of scholarship around the question of privacy and surveillance, and especially in relationship to immigration and border control. And she's written two books related to this topic: Science at the Borders, Immigrant Medical Inspection and the Shaping of the Modern Industrial Labor Force, and Searching Eyes, Privacy, the State, and Disease Surveillance in America. Professor Quayshawn Spencer is our third panelist. He is the Robert Blank Presidential Associate Professor of Philosophy at the University of Pennsylvania. And Professor Spencer specializes in the philosophy of science, the philosophy of biology, and the philosophy of race, and has spent a lot of time thinking about the problem of natural kinds in biology and medicine. In the philosophy of biology, he's done substantial work on metaphysical problems in biology, such as whether biological populations can have what are called fuzzy temporal parts, and whether there's any way to group organisms into biologically real subspecies. And in the philosophy of race, his work focuses on the metaphysical problems in race theory, such as whether any folk racial classifications divides people into real biological groups. We have a format for today in which we're inviting each of the three panelists to speak for roughly 10 minutes on their own background, their own disciplinary perspective, and how their own research informs this question of how one looks at the potential challenges that are wrapped up in the development of genomics technologies at the intersection of these questions that we've foregrounded, specifically when infectious disease and genomics technologies comes together. How do we think backwards at earlier conversations about genetics and infectious disease and questions of susceptibility, both seed and soil questions in infectious disease and heredity questions, and how concepts of susceptibility can be linked to populations and become the basis for stereotypical judgments that can have actually substantial social consequences. In terms of surveillance, these technologies can be used to provide forms of, especially in questions of how genotyping of infectious disease can trace the actions of individuals. How might it raise new questions in terms of what becomes visible in the eyes of the state or a corporation? And in terms of stigma, there's a broad series of questions here as we can looking back on prior management, both of genetic technologies and of the management of infectious disease, that the marker of risk or of disease can bring with it substantial stigma that can affect individuals and populations in ways that were not initially foreseen. So here we have this panel of experts to explore how screening technologies for infectious and non-infectious diseases have been used over time to understand and categorize not only disease, but also the people that have these diseases. And I'm really looking forward to how this conversation unfolds. So after these first three talks, I will ask a few questions to the moderator, and then we'll open it up for a general discussion. And so, Robin, I'm going to hand it to you to kick us off.
All right. Thank you very much, Jeremy, and good evening to all of you from, I'm looking at the guest list, I think almost all the way around the world. I'm really happy and honored to be here today. I want to thank Johns Hopkins Berman Institute and the Levi family for putting this together and for inviting me. As Jeremy mentioned, I am a historian of the life sciences and biomedicine, and in a very broad sense, a lot of my work focuses on understanding the social relationships of molecules over the course of the 20th century. And I think this is an important perspective here because, well, the pace of biotechnological and biomedical innovation appears to be accelerating very rapidly on a day-by-day basis. I mean, I lived just a virus's drift from so the Moderna labs, where one of the vaccines for COVID was developed. There's nonetheless a series of questions that people from the history of science and medicine have asked about prior iterations of technological innovation, which I think are worth asking now as we sort of approach this question of what genomic analysis can offer our appreciation of infectious diseases. And I think one of the big points I'll be thinking about in reference to some of the studies I've done of cancer viruses and the relationship to molecular genetics is precisely the ways that we use technical innovations and potentially invest in them as a way of making the peaks of our knowledge higher while leaving certain valleys unexplored. And that's both an intellectual question and an institutional question about the types of policies that nations and philanthropies pursue. And I guess in an art historical terms, that seeing in one way often means not seeing in another way. And as we think about any new technology, we have to think about how the vision and scope it gives us of understanding a disease in that way might also foreclose other beneficial ways of thinking and talking about that disease. I think that's especially true as we address the current challenges of the global pandemic. But I'm going to now step more deeply back into time in the case of cancer, which of course is a greatly feared disease in the early 20th century, was gaining its sort of dread status as the #1 sort of challenge facing many branches of medicine and science. And indeed, it's one of the first deeply interdisciplinary disease challenges to the institutions of medicine in the United States. It attracts the attention of surgeons, of pathologists, of cell biologists, of microbiologists, and others. And the thing that's interesting here is that the debates over cancer's causes and cures in the early 20th century highlight this disjuncture. There's so many different ways of describing the disease that they're almost incommensurable. So people enthused by the prospects of germ theory were willing to seriously consider that there might be cancer causing microbes based on their sort of study of diseases within the laboratory, only to have that type of intuition flatly rejected by people who worked in the clinic, either nurses or surgeons who would say that their own experience of working with patients with cancer, rebutted that type of contention. And indeed, the more that money was invested in cancer, these types of disagreements over how to even understand a disease like cancer only became heightened. These sort of conflicts between different traditions within science and medicine. And I'm going to sort of highlight how a few of those traditions interact with each other as it comes to sort of this quest for a cancer vaccine and the search for a human cancer virus to pin it to. And it's another one of these things that we can commit the error of making is thinking that big science or big data are once again big, novel and new creations to the moment, to the present crisis. But in the mid-1960s, the National Cancer Institute creates a series of programs dedicated to searching for a human cancer virus that are in fact larger than the Human Genome Project. They pump billions of dollars into areas of research that do not necessarily have a large amount of activity in them. They sort of create whole fields, and they do so based on a very interesting reason. And of course, I would like to show you the virus they discovered that justified their faith in having a human cancer vaccine. And of course, I can't quite do that because viruses exist beneath the level of human visual perception. But the other reason I can't do it is because the virus didn't exist when the program was established, nor did the virus exist during the time the program was in operation. It was an object of administration. It reflected the conviction of the leaders of the National Cancer Institute that there was a way of anticipating and accelerating technological development in biomedicine rather than simply waiting for the laboratory to provide them with the information that they needed. So they wanted to sort of anticipate and steer research towards a therapeutic goal. And they were, of course, greatly enthused by the success of the polio vaccine in the 1950s, as well as the types of technological breakthroughs promised by sort of the moonshot management strategies being used at NASA at the same time. And these were marshaled in the service of developing a vaccine, much to the bemusement of many people working in virology and oncology more broadly, who were still deeply skeptical that there was a human cancer virus worth finding. And in accord with that faith in organization and anticipation, the types of work that the National Cancer Institute sponsored emphasized the infrastructure, the institutional organization of the search for a cancer virus, and in the process really amplified a series of ways of understanding cancer that wouldn't necessarily have been as well developed if not for this anticipatory investment. And in particular, there's two that I think are relevant to our discussion today. The first is large-scale serological epidemiological surveillance of populations around the world on the hope that the pattern of cancer incidence and observations of their blood would yield a discovery of an agent that could be associated with cancer using the familiar framework of germ theory. And the most notable effort here actually doesn't occur in the United States. It happens within Uganda in East Africa, where following in a tradition of tropical medicine and observation, there's the hope that thousands of children in Uganda could be followed and to catch a few cases of Burkitt lymphoma, which is a lymphoma commonly found in sub-Saharan Africa that was thought to be associated with a viral cause. But the act of carrying out this type of surveillance, which also drew in the International Association for Cancer Research and a number of other development groups, began to pose other new ethical questions. People began within the program to ask why they were extracting blood and information from these children for the sake of advancing knowledge that would be seen as useful for people in the United States. There wasn't necessarily a therapeutic promise that any of this knowledge was going to be used within Uganda, and there are also broader questions as to how do you justify investing in this type of survey work versus the many other public health needs that were on the table, such as addressing malaria, smallpox vaccination, and other tasks, and the relationship between those. And this, of course, is a long-standing question with many forms of surveillance, which is what populations are being asked to yield versus what they can expect to have returned to them. And of course, this comes from the type of extensive scope and scale of investment in serological searches for cancer viruses. So that's the first one. The second one is less significant in monetary terms, because these searches were like big science and on a scale that most oncology had yet to reach. But the other one is a bit smaller. It focuses on trying to understand the nature of what a human cancer virus might look like. And ironically, this search is motivated by the frustration of the National Cancer Institute after a few years that its large-scale epidemiological work hadn't yielded any demonstration of a human cancer virus's existence. And the leader of that program, Robert Huebner, tries to find a theory of what viruses are that will account for both viral carcinogenesis, but also why the traditional methods of immunology and virology had not identified a virus and associated it with any type of cancer. And here, Huebner reaches back to sort of earlier theories of what caused cancer in the 1920s and 1930s that were sort of formulated by studies of mice. And this is very importantly a time when the distinction between viruses and genes was not firmly articulated. So whether or not viruses are their own organisms or simply agents of heredity is an open question. And along with this, the types of transmission associated with cancer viruses is more expansive. It's possible to talk about both the vertical transmission of cancer, which is sort of seen as potentially sort of a hereditary relationship from parent to child, but also the so-called horizontal transmission, which is the type of transmission that we're familiar with, where you sort of pass a virus from one organism to another. And indeed, some of the people who had been studying work with nursing mice had gone so far as to request that their children be formula fed out of fear that they were somehow the feeding process would be transmitting a virus to another generation. So there's that idea, and Huebner combines that idea, the idea that some type of vertical transmission of cancer that viruses might be involved in, with work in molecular biology on E. coli and bacteriophage, showing that bacteriophages are somehow inserting a DNA blueprint of themselves into bacteria, which only becomes a fatal infection several generations later. This is the phenomenon known as lysogeny. And Huebner puts these together in 1969 to propose something called the viral oncogene theory, which is to argue that these RNA, a certain type of virus, RNA tumor viruses, otherwise known as retroviruses, and the same family as HIV and others, are sort of can possess these dual natures as both infectious agents and agents of heredity, transmitting a viral oncogene upon infection into a cell in which it could remain dormant through several generations before turning into full-blown cancer at a later point, which would explain how you could have cancers without any detection of the virus. I won't belabor that this idea is deeply controversial for molecular biologists, and it's only because Huebner has the resources of this anticipatory program the National Cancer Institute is running that he's able to supercharge this work, and it proliferates very rapidly in the early 1970s. Hundreds of millions of dollars go into it. And the ironic outcome of this search is that in 1976, a laboratory at the University of California, San Francisco, demonstrates the opposite. There's actually not viral oncogenes, but cellular oncogenes. And this is the first time that I believe that a gene is physically isolated and tied to the incidence of a particular disease. And that gene SRC sort of opens up a new idea of how to understand cancer as a molecular genetic phenomena that is extended to humans in 1982 with the sort of identification of the first human oncogene. And this marks a dramatic reorientation of laboratory and molecular studies of cancer from looking for enemies without to sort of studying the roots of enemies within. But it also entails a series of foreclosed opportunities for talking about cancer in the early 1980s, which is a moment when, in the aftermath of President Nixon's war on cancer, there's a lot of frustration with sort of a laboratory-based approach or a therapeutic-based approach, and people are beginning to ask questions about, say, cancer causation or access to care and screening technologies for cancer. But within the frame of talking about the molecular genetics of cancer, those questions are harder to discuss, and it also coincides with reasserting a certain sense of community around the problem of cancer. So, for example, studies of hepatitis B in Taiwan that demonstrate the link between hepatitis B infection and liver cancer are considered not to really be a useful discovery to have, precisely because it's not a type of cancer incidence that affects people in the United States. And there's some really salty exchanges that happened at the National Cancer Institute in the late 70s between molecular virologists and epidemiologists over how to understand this problem. And the lasting sort of question that shadows a number of ways of understanding cancer at the molecular level in the slide is that the molecular vision of cancer makes it much harder to talk about some of these broader social concerns. And this has been something critics have been quick to note. There's nothing about an oncogene that tells you, for example, about how to reduce smoking. And there's nothing about identifying an oncogene that immediately suggests therapeutic a beneficial therapeutic outcome for the person who's been diagnosed with it. Indeed, it really surfaces some of these concerns about shame and stigma that people had been at pains to try to expunge from discussions of cancer earlier in the century. And this is sort of the molecular view of what medicine could be that also powerfully feeds into sort of the explosion of genomics in the 1990s. And it's the tension that I face today as I'm working on my second project on the history of the biotechnology industry in Boston, which is a whole entrepreneurial ecosystem that incorporates other elements, but around this fundamental vision that the way of addressing the problem of disease is at the level of the molecule. Cambridge also has one of the most advanced sewage surveillance systems, which in the country, I think, thanks to these startup companies, which have been used for opioids and now has been turned to monitoring for coronavirus. But at the same time that work is happening, you can travel just a few miles and you find, just like Baltimore, communities where getting the very, 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 very minimum of care is still a huge challenge. And I think for people who think and work in bioethics, this is sort of an element that we don't often discuss, which is sort of the policy and structural questions that go into making bioethical decisions. And those are things that ramify back, in my mind, not only to what we do with this information, but also the very information we give ourselves to reckon with the problem of disease as a whole. So thank you very much.
Thanks so much, Robin. And I had failed to mention at the beginning, I know I mentioned some other books, but that I'll put it in the chat as well, that Robin Scheffler's first book, A Contagious Cause, The American Hunt for Cancer Viruses and the Rise of Molecular Medicine, sits exactly at this intersection, as has just been illustrated. I'll put an Amazon link in the chat as well, so you can all be aware of this basis of scholarship. So I want to turn it over to you, to Amy Fairchild, for next comments.
Thank you, Jeremy. And I'm going to pick up, and thank you, Robin. I'm going to pick up essentially where you left off with some of the policy and structural questions, but also some of the pragmatic questions related to disease and surveillance. And so I have been less, until quite recently in my own career, less engaged with questions of infectious disease and genetics, but the COVID-19 pandemic has brought me into that realm. And let me give you a sense of how my career has been framed. It's been framed by the AIDS epidemic on the front end, and it's been framed by COVID-19 on the back end. And though I still have some years to my career yet, I don't want to suggest that the book ends are up and that I'm done. But so I started my work in the history of public health at Columbia University. And one of the things that I did after I had done my coursework, I felt like I didn't really have a strong enough sense of how public health worked, the politics of public health, the day in, day out the pragmatic practice of public health. So I spent nearly 4 years working at the New York State Department of Health AIDS Institute. And I was there from about 1990 to 1994. And of course, this is a period in time in which New York is one of the national US epicenters of the pandemic, one of the global epicenters of the pandemic. The stigma around HIV/AIDS was still enormous. We didn't yet have the benefit of heart treatment. And both AIDS cases and AIDS deaths were reaching their national peaks during this moment in time. So it was a really intense period to be engaged in policy. And the charge for the handful of us, and it was like 4 or 5 of us, who worked in the policy unit, was to help advise the New York State Department of Health AIDS Institute on some of the pressing policy and ethical challenges of the day. And of the many things we worked on, the things that really captured my attention as a scholar and somebody interested in the practical control of the problems that we were facing as a nation were controversies around surveillance. And so we were directly engaged in two big controversies and debates. The first was the unblinding of newborn seroprevalence studies. So in 1988, when blinded seroprevalence studies first began among newborns, these were they happened in hospitals. Newborns would be tested for a variety of conditions, and they would take a sample of that from the heel stick. It was stripped of all identifiers, and they would test it for HIV. And it was a way to give some insight at some sentinel hospitals into what the levels of infection were in the community at a moment in time in places like New York State, when we didn't have mandatory HIV reporting. As it became clear that the administration of ACT before the birth of a child and during childbirth could dramatically reduce maternal fetal transmission, it became much harder to justify any kind of testing in which results couldn't be shared back with individuals. But of course, the challenge in this case was that when you tested newborns for HIV, you only knew whether the newborn had been exposed. You did know whether the mother had HIV or not. So it really became a means of mandatory testing for pregnant, mandatory unconsented testing for pregnant women. So that was one of the controversies that caught my imagination and my attention. And the other was the controversy over HIV name-based reporting. New York State was one of the last states to move to name-based reporting in the 1990s. And what had happened by that time, really after 1985, when we had access to HIV testing, it became quite clear that tracking AIDS cases really wasn't adequate to understanding where the pandemic was moving. It wasn't adequate to know where you were going to have AIDS cases, and we really in public health needed to know where HIV infections were, where were the hotspots, where did resources need to be directed. But of course, in New York, this was just continued to be a flashpoint, particularly in the gay community in the 1990s. And the challenge there was that, again, this is a moment in time in which you still had enormous stigma and fear. And for activists in the gay community, the threat of public health intervention, and I can't underscore this enough, was as great as the threat of the disease itself. And that's quite a remarkable thing to think about. The prospect of the health department intervening to help contain the pandemic was far more threatening to people than the disease was, at a time in which it was still widely referred to as a death sentence. So this really got me interested in the history of public health surveillance, and I dumped all the research that I had been planning on doing for my dissertation / first book on the patient experience of disease. And in looking at this history, I did this with my colleagues, Ron Baer and James Colgrove, we looked at it from the end of the 19th century through really the concerns about emerging infections and bioterrorism and biowarfare. What surprised me were that even though it was these clashes about over HIV that drew me in, and it was the history of how surveillance could be threatening, how it could be stigmatizing, how it could be used for discriminatory purposes. What surprised me was that despite some of these clashes, you saw the same thing with tuberculosis, sexually transmitted infections like venereal disease in the 1920s and 30s and on, birth defects surveillance, obesity surveillance. The bigger theme that surprised me was not that there was this long history of resistance to surveillance in the name of privacy that had taken different forms over the course of a century, but what surprised me was the degree to which populations were demanding surveillance, because it was a means to identify problems and direct resources. So in the case of women in breast cancer, they were demanding the right to know. In the case of workers who were working in industrial settings and were exposed to chemicals and other industrial hazards, they were demanding the right to be counted. And the animating idea here was that what doesn't get counted doesn't count. So it's sort of a parallel. It's a sort of a parallel to what Robin laid out when he said, seeing one thing is a means of not seeing another thing. So there were people who were being seen and people who were not being seen, and there were real harms to not being counted. And that's what you also had advocates wanting surveillance based on this idea that who but the state is going to come in and address some of these structural issues, who's going to address issues of access to care, who's going to address issues of toxic industrial workplaces, of toxic exposures in the environment. So that really introduced me to the history of surveillance and frames the way I think about it. And of course, now here on the tail end, as Dean of the College of Public Health in the middle of a pandemic, and I had been here a whole whopping, I think, 7 months before the pandemic hit and shut us all down in this role. But one of the things that happened is that I became responsible for a group that's doing all of the monitoring of COVID on the Ohio State University campus. And we're a campus of some 66,000 people. So we are big, and it was like creating a little health department, albeit a narrowly focused one, almost overnight. We began testing all students. We engaged in wastewater surveillance, and we're now doing dust sampling in residence halls and dormitories. And we began genetic screening of the samples. And that was a transformative moment for me in thinking about the importance of genetic screening. I've been somebody who had been critical of the idea of precision public health for precisely the reasons that Robin laid out. I was concerned it was going to take us away from addressing the broader social determinants of disease and lead to more reductionist views of disease and personal responsibility for disease. But at a gross level, knowing what variants were predominating on campus definitely affected the recommendations my group has been making about how aggressively to intervene, how adamant to be about interventions like masking and routine testing of the unvaccinated. And in a more granular level, this hasn't happened at OSU. It takes more resources than we have. We've seen examples from places like the Netherlands that have been using genomics to provide reliable assessments of community transmission. And this is something that's been done in HIV/AIDS too, that if you know what the genetic sequence of the virus that you're infected with, you can determine network groups and who's interacting with who and how virus is being transmitted. So and one of the things I've seen in this role too is, of course, I have faculty who are working with the Ohio Department of Health, or who are working with state and local health departments. And I'm reminded of those old themes of the lack of resources, the lack of data, the challenges of not having data that are interoperable, and the barriers that creates to identifying those communities most in need. And if you think about precision public health as being getting the resources to the populations that need them in a timely way, some of those barriers really do affect the capacity to see which communities are hardest hit by COVID-19 and get the right kind of resources there in the right way.
Thanks so much, Amy, for that. And so many questions to ask you in there. The way you're concluding with this question of how the technology itself is somewhat agnostic as to whether it's used to increase equity or increase disparity. And that's a question I want to make sure we get to come back to. I want to turn over the podium to Quayshawn Spencer, but also while mentioning books that should be mentioned that I want to draw our attention. I'll put this also in the list that Quayshawn has also recently came out on a very important co-authored volume called What is Race? 4 Philosophical Views, that came out in 2019, along with Joshua Glasgow, Sally Haslinger, and Chika Jeffers. So hopefully I'm getting most of the books. We'll get a slight Amazon sidebar for the panel by the end of this. But I want to turn this over to you, Quayshawn.
Thank you. And I just want to reiterate Robin and Amy's great thanks for the invite. It's a pleasure. It's an honor. And I look forward to the conversation that we're going to have tonight. So as was mentioned earlier, I am the lone philosopher on the panel. I have some background in history of science, but I could not call myself a historian of science. But I'll say a little bit about how I got into the type of philosophy that I do, which is philosophy of race, philosophy of biology, and philosophy of science, and step through 4 big questions that I've been addressing in my career. And you can see how this is relevant to today's discussion. So I started off pretty much as a scientist that went AWOL. I was big into biochemistry, even won my state's biochemistry part of the science fair senior in high school. I was in Tennessee. Went to college, and then I got really enamored with philosophy, but not enough to sort of pull me away from science. But then I took this course, this advanced philosophy of science course in my university, where we actually did some philosophy of science that wasn't just in the sky, all theoretical, but was really dealing with some pressing social issues at the time. The book was The Bell Curve, and the author was Ernestine and Murray. Some of you already know who these people are. But these were social scientists who dabbled not just social science, but also a little genetics. Basically, they were looking at ways of measuring intellectual cognitive ability, as they said, tests for that. And lo and behold, they found disparities between racial groups. And lo and behold, they thought that part of the best explanation for the disparities was genetic. Now, it's a very complicated sort of debate that followed. But what struck me as interesting was how philosophers can contribute to the debate. So you can ask questions about statistical design and such. But at the end of the course, the professor raised this question, are races even natural kinds? And there's this literature in philosophy about how we even start science, how we even classify things that are appropriate things to look at in order to recognize patterns. And so take, for example, if you took the variables Democrat and Republican, which might seem like very robust variables these days, but we're in a context of biology, let's say, and you looked at statistical patterns among Democrats and Republicans in the US, you might find things like, well, Democrats are more likely to have sickle cell anemia. Well, that's probably true because most Democrats are African American, and African Americans comprise about 85% of people with sickle cell disease in the country. But it's an accident, right? It's accidental. It's not something that wouldn't fall away under other sort of circumstances. We want something more stable in science. And so trying to look for those classifications that give you stable, non-accidental generalizations is the work of natural kind theory and philosophy of science. So that was my first question, and I developed a theory. I call it genuine kind theory. I expanded it to genuine entity theory because I thought kinds were too limiting to look at the stuff I was interested in. Particulars and kinds are different sorts of things in philosophy. Take university, it's a kind of thing. You can be a member of that group based on certain properties. But then particulars are just single instances of things. So Johns Hopkins University would be a particular university, and university would be a kind. So I expanded to genuine entity, genuine scientific entity theory. And basically the idea is this: what scientists are interested in is they're trying to get generalizations with classifications, stable generalizations that give them long-term scientific success. And if you look at sort of the paradigm cases of what those things are, and you rule out from the history of science the sorts of things that we've certainly say aren't the sorts of things we should be looking at, you can get some criteria like the following. The entity that you're picking out should be useful and justified in a well-ordered scientific research program. So that's the definition I came up with. Those have a little bit more flair to them when you unpack them. But basically, there's two kinds of scientifically genuine entities. One is basically used to get science started for observations. I call them relative a priori entities, but that's some fancy jargon just for the sorts of things that you throw out there that make generalizations possible. And then there are what I call properly empirical entities, but these are you could just call them theoretical entities, because these are the things that you posit in science to make sense of the patterns that you're seeing in the observations, right? So you have these two classes of scientifically real entities. So the question then becomes, well, what is race? So that's my second question. What is race? And I have a book that I wrote with some other philosophers to try to tackle that. And in particular, in the context of the United States. And the dialectic so far in philosophy has been fourfold. And it's been focused on the biological and whether it's real or not. So there's the people who think that race is biological and real. People like Louis Outlaw at Vanderbilt was one of the first to argue that. And then to people who thought that race is biological and unreal, like Anthony Appiah at NYU, he was a big proponent of that. And then came along people who thought that race was not biological and real. This is actually the most popular view outside of philosophy, but it's a contentious view in philosophy. People like Sally Hasling at MIT have argued for that. And then for logical tidiness, there should be people who think that race is not biological, non-real, but actually there aren't any people who've published in that. So if you want to go out and publish a philosophy paper, that's where I would recommend putting in some work. Now, in the past, people have committed themselves to one of these basically practically three positions. But recent work that I've been doing shows that if you want to be nice, all of them are partially right. If you want to be strictly speaking correct, all of them are wrong. So if you look at all the empirical data that needs to be explained, I argue that there isn't a single race theory that accounts for all that. And instead, what we have is a plurality of things that we call race. And so I call it radical pluralism in the literature. And so to give you a flavor of what this looks like, I think that the federal government is using basically a five-fold subdivision of geographic ancestry groups. They've been doing this since 1997 from the Office of Management and Budget, basically Blacks, whites, Native Americans, Pacific Islanders, and Asians. So this is an ancestry thing. You can argue that it's biological. But then we have these ways of divvying up people into races that are not biological. They look biological, but they're actually sorting people according to properties that are social purely. So Haslanger has this view called racialized groups. And the terminology racialized group is actually popular in the literature, but her version is that these groups look like the geographic ancestry groups, but what they're really are groups that are organized by social privilege and disadvantage. So that's another thing I think we're talking about with race. But then there are also people who argue, like Anthony Appiah, that we have this language of racial identities. And so this can come apart from how other people position you socially, what your geographic ancestry is. It's something about your psychological connection to a particular group, right? So I think these are at least the three that are going on in contemporary US. So now it brings us to, well, how does this connect with medicine, in particular, the genomic revolution in medicine? How are we supposed to think about racial classification in medicine? And so first I had this epistemic program, which is just thinking about how can you use some racial classification and get knowledge in medicine without leaving aside reservations about whether we should use any racial classification in any form of medicine. And I found that you could use geographic ancestry groups as these relative a priori sort of genuine entities, insofar as without any prior knowledge about where to look for certain patterns in the human genome. One thing you might want to do to have good science is to have a racially diverse sample. So there's a good example of this in the literature that I can use to sort of illustrate the importance of this. Zheng Yang et al. 2011. There's a group of scientists that were studying acute lymphoblastic leukemia in children in the United States. It was a cohort that was partly in Tennessee, partly in California. Go Tennessee. And they were trying to figure out if there was any sort of racial connection to the drug response of the typical sort of chemotherapy that's given for that particular cancer. And they did a clinical trial, NIH sort of funded. And so they had to use these 5 geographic ancestry groups, but they didn't take the self-reports too seriously. So they're setting aside the racial identities and stuff. And they sampled because they had a hypothesis that Native Americans weren't responding well to the standard chemotherapy. And so they took not just people who were registered tribal members, but also lots of mestizo Hispanics, right? And if you know something about sort of how Hispanic Americans self-identify racially, they tend not to identify as Native American. But that doesn't mean that they don't have a lot of Native American ancestry, which they typically do, especially if you're Mexican American, which is the most prominent Hispanic American in the country. So they did that. So they deliberately packed the sample with people who had lots of Native American ancestry and was racially diverse in general, which not a random sample of Americans, because if you randomly sampled Americans, you would have like 80% non-Hispanic white folks, or 70%. I don't know what the census come out with recently. And they actually found 2 alleles that were correlated with having twice as much chance of relapse after doing the standard chemotherapy. They found that people with these alleles just would take a second round of chemotherapy, and you can actually get rid of that pattern. So this was a concrete sort of thing that they found by ignoring racial identities and looking at geographic ancestries. So that, I think, is a usefulness that you can get out of at least one racial classification. And then the next problem is, should we be doing any of this, especially in light of the history of medicine in this country and elsewhere, which I think we'll probably get into in a lot of detail. But there's lots of risks here. So there's this sociologist, Brian Donovan, has done some work showing that people who aren't well educated in even just Mendelian genetics, basic classical genetics, tend to develop racist attitudes when they hear about genetic diseases, in particular in racial language. Just using the variable at all tends to increase people's racist attitudes for this class of people who don't have a background in classical genetics. So that's something you want to think about. Should we even be using race variables, even if you can get better samples and find rare alleles that can turn out to have better, allow us to design better drugs? Well, I'm not a bioethicist, but I've been pushed in that direction. I'm very interested in philosophy of medicine, but I've been getting more interested in bioethics. But luckily, I have a bioethics graduate student who I'm advising his dissertation. And we've been working on a virtue ethics approach to addressing this question. I'm not even a virtue ethicist. I'm more of a Kantian, and these are sort of positions in moral philosophy we can get into later. But I think the virtue ethicist, in particular, Jorge Garcia, has come up with this theory of racism out of the philosophical literature. It's called the volitional theory of racism. We'll probably get into that a little bit more. But basically, what you're concerned about when you're using racial classifications in medicine, and genomic medicine in particular, is promoting racism, right? So then we have to think about, well, how do you not do that? And so we've been coming up with not just tinkering with Jorge Garcia's theory of racism to make it applicable to the medical field, but also giving some criteria that together are necessary and sufficient for deciding whether you should be using a particular racial classification or not. And we can get into that more later, but that's all I got for now.
Thanks so much for that, all 3 of you. And actually, just lingering on that last observation, which is a study that I'm not familiar with, but I'm interested in learning more. The suggestion almost that that an exposure to genomics in conversation with racial categories among a population of folks who are relatively underexposed to education in Mendelian genetics will produce more racist beliefs. We'll sort of, it almost sounds like you're articulating a 2-hit hypothesis, just to take us back to Robin's studies of cancer, that it's almost like here is a way in which a potential emergent hazard for the increasing use of genomic technologies in conversation with race and infectious disease is just this. It will unleash kind of almost a reflex medical expression of medical racist thought. And I'd love to follow up back on that and perhaps even take us back to Robin to begin there. I have a few questions, but one is that your first book studied the role of infectious disease, oncoviruses, in the development of the study of cancer genetics. And your second book captures this evolving role of genomics in the biotech sector today. And so this is a question for Robin, but also for Amy and Quayshawn, that as we read across these varied historical examples, past and present, which elements of genomics today do you find most potentially concerning as genomic technologies become an increasingly accepted practice in public health? Quayshawn has just given us one challenge at the very end, that using more genomics in conversation with the category of race and infectious disease will precipitate more casual biological racism in general populations. What other hazards do you see in this space?
Shall I take a first attempt at answering that? So I think that it maybe is a related case, but based on my reading of sort of some of the literature on how genomics data sets are being constructed for surveillance, I think that there is really a deep need to be very aware of how the information the genomics has this sheen of being just information. And of course, anyone who does work in it understands there's a lot of choices that go into making that sort of information appear frictionless. And in a whole host of settings, I think that by the time, you reach that level of not even the public, but either sort of policy making, a lot of that work is obscured or forgotten about in ways that can produce, a less than helpful understanding of what the information could do. And I still, I'm gratified that sort of the work where there's I have a bit of a challenge. I both sort of think that the food could be better, but also there's not enough of it when it comes to sort of some of these science and policy moments. I do in a broader sense than simply like having information or not having information in a genomic sense. I'm concerned that how our society decides to take on disease challenges in the long term can still be sort of led in slightly astray, or we will find ourselves in moments that seem confounding unless we sort of keep very heavy sea anchor outside of genomics. And I think there's a number of those examples at hand where when you get to that point of saying what do we do with this information, sometimes the answer seems very easy based on the genomics sequence, but that is actually deeply difficult to actually implement, or it poses all these other questions. And the times when it works is a sign that a lot of other things have worked alongside simply having, the right data or the right sequences.
Well, I was also, Jeremy and Quayshawn, I was also struck by that statement, and I had two reactions to it. First, I think we've seen it happen in the context of COVID-19. It's one of the rationales for the CDC and World Health Organization moving away from characterizing different variants of concern as the Brazilian variant, or the South African variant, or the Indian variant, and moving to Delta, Gamma, Alpha, Mu, the next series of variants. And I was surprised that new terminology has taken off, and I think that's a good thing. But the other reaction I had to it was, is that just true of genetic diseases? So I think the whole history of public health is that we see anytime you associate a race or a nationality with a disease, you trigger racism. And I think the challenge that we always face in public health is that when you teach public health, you're so steeped in laying out the disparities that emerge between racial groups, between ethnic groups, between classes, between men and women, and we often forget to specify the pathways that we think that's working through. Is it environmental exposure? Is it a whole host of things? Is it energy insecurity? Is it risky occupations? And I do think that not laying out the pathways and the pathways are different if you're talking about something that's not genetic. And so, but even when you can point to some very specific pathways, if you don't do that, the default becomes, well, it's bad behavior, bad character, bad neighborhoods, unsolvable problems, and people that we ought to shun and exclude and segregate in the various ways that we have done so consistently in this country.
Could I ask a follow-up on that, Amy? Do you think that bad behavior and bad, so all these personalized things, is it coming from a biologizing of the culture? Is that the suggestion? Or?
I think it's, well, you're right. So I think it's two things. I think it can be biologizing of the culture, and I think it can then also be genetic reductionism. That those groups are just those are different. Those groups are different from the rest of us.
Yeah, I guess I'll just I should give a shout out to my PhD student Ian Peebles. So he's isolated not just this racist attitudes problem, but also some other things that tend to come up in history of medicine, but are live concerns now with the advent of genomics. Overemphasizing, and Amy got into this a little bit, overemphasizing genomic explanations over social explanations that don't have anything to do, at least directly, with genomics. It's always complicated because there could be an indirect link. It's like, why are these people getting treated this way? Well, they do have dark skin. Dark skin is genetic, but but the direct sort of social determinants is what tends to get less attention when we focus too much on genomic stuff. And then also, don't forget sort of reinstating concerning racial hierarchies of the past. So, I mean, this is just a part of the history of the United States that we started off with medical scientists giving the sort of biological evidence for the treatment of African Americans and Native Americans in the way that we did. Like an example that I like to use with my students is Samuel Morton, who was, he was a Penn alum and affiliated with all sorts of medical establishments in Philadelphia. And he was big on skulls and measuring people's skulls and doing all this stuff with skulls. And the gist is he came up with this racial hierarchy based on skull measurements, which is supposed to be indicative of intellectual endowment, something like that. But then the payoff for politics was there were actual politicians that referenced his science, cited his science. We annexed Texas partly based on the Secretary of State citing Samuel Morton's science, right? So why should we we annexed Texas as a slave state. That's how we introduced Texas into the Union. There was a debate about whether it should be coming to the Union as a slave state or not. Obviously, you've got these medical experts, saying these people should continue to be property. And that's a live concern, not to the same extent as back in the 1800s when this happened, but still, I mean, there's ways of reinstating concerning racial hierarchies with the new genomics.
So, and I had one final thing to add, riffing on it, which is also that with the emergence of entrepreneurial biotechnology is another way of making knowledge in genomics, not just relying on, say, academic or state-based ways. Like there are occasionally entrepreneurial reasons to amplify racial difference. You have marketing strategies that are grounded in producing drugs to fit the genomic profile, or in the case of Badil, self-identified members of a racial group, as opposed to, which just gets back to this question of what type of kind do we have. So there's also other sort of forces within the market that could hypothetically work to also try to parse different types of differences that were within this vast field of new genomic data.
So this is such an important topic to linger on. I mean, one thing I would like to just draw a connection to, if it seems appropriate, is, Quayshawn, you offered this very helpful typology, this 2x2 box of whether race is biological, not biological, real or not real, right? And yet it seems that part of what we hear Robin and Amy talking about is that the slippage and the danger that happens when we lean on programs in public health that rely on a technology that equates the biological and the real. And that part of what happens with genomic models, if I'm reading you correctly, Robin, is that it's not to say that trying to invest in the possibility of an idealized object of detection and surveillance is itself entirely misguided. So much of biomedical work and public health work happens that way, but it has the after effect of drawing the gaze away from other things, so that when differences are found in genomic samples from enriched and broadly diverse ancestry groups, and then differences are found in infectious disease, morbidity, mortality, prevalence between groups, the quick connection is to go to that ancestry as being the biological and the real determinant, as opposed to social patterns, and among other things, racism itself, right, as something which could actually be the causative link in showing differences in actual disease patterns and mortality. That we have this tendency to then, that the technology can bring with it an accidental and slippery equation of the biological and the real, which might not necessarily be the case.
Yeah, let me jump in. So, I mean, here's the problem. This is what me and Peebles have been thinking about. Yes, there's a risk to making something or focusing too much on the genomic when you should be focusing on the social, but there's also a risk to focusing too much on the social and not enough on the genomic. So let me give an example. My father was a Black Panther affiliate when he was, he didn't do anything. FBI, if you're listening, he's not, he wasn't a member, he was just affiliate, he was on the up and up. He was actually a molecular biologist who trained Black Panthers to do certain medical procedures. Now, one thing the Panthers were really interested in were these ignored genomic diseases like sickle cell disease, right? So what you can do is you could look at the risk of focusing too much on the genomics versus the social, or vice versa, by thinking about the penetrance of the alleles that cause the disease, right? So penetrance is a fancy notion in genomics about sort of the probability of developing the disease based on the genotype that's supposed to code for it. Now, the penetrance of certain diseases are very low, given the sort of genomics that are tied to it. But for sickle cell, it's actually quite high, right? So the risk there is not focusing on the genomic stuff enough. Now, finally, thankfully, and so let me iron out this risk a little bit more. When you're not focusing on the genomic, because basically this disease, you're producing sickled cells that are deformed in a certain way, that will cause traffic jams in your body. If you don't get enough blood to an organ, you can have organ failure. People with this disease tend to die much earlier than the average American. This disease is overrepresented in African Americans. Not much has been done on it at all in medicine until recently. What we've been doing up until this point is basically just making people feel comfortable, trying to get them an extra year on their life. We've been treating symptoms, not the root cause. The root cause is genomic. Now, in comes Jennifer Doudna and the development of CRISPR-Cas9. And now what we're doing is we're doing some clinical studies where we're actually changing the genomic sequences of the cells that are able to produce other blood cells in the bone marrow, and replenishing the cells in the body, the blood cells in the body that were previously overpopulated with sickled cells. The clinical results look very good so far. Of course, it's too early to say when you roll this out on a grand scale what it's going to look like. But they're not focusing on the genomic is actually just decreasing the lifespans of people with sickle cell disease, or at least keeping their lifespans lower than they need to be if we develop medical technologies that could expand them. And it's overwhelmingly disproportionately impacting African Americans. Over 80% of people with sickle cell disease in the United States are African Americans, right? So there's a risk here. And so I think what you have to have is a certain sort of fine-grained ethical sort of addressing of, when do you do it and when don't you? And that's a hard problem. It's not just never do it, because if you never do it, what tends to happen is minorities get the short end of that stick.
Quayshawn, that's a great point. And one of the things I would just point out, add to that is to think about Alondra Nelson's fabulous book, Body and Soul. And it is important to remember that the Black Panthers were also concerned with genetic diseases, also concerned with sickle cell, but certainly the vast majority of their efforts went into trying to provide food in communities, childcare, and they inspired groups like the Young Lords, who were focused on in New York City, who were focused on tuberculosis and lead paint testing, which of course had the way that history unfolded in New York is that the early analysis of seeing high levels of childhood lead poisoning in communities living in what they called the lead belt in New York City was that this was pica. So it's a disease that Black and brown kids had that caused them to eat paint. So I think that, and I haven't looked at that history from a genetic lens, but I think it's an interesting connection. But I think it's still important to emphasize that the sort of where the vast majority of the efforts of groups like the Black Panthers was going, it was creating more equitable social conditions. And I think that speaks to the question that Karen put into the chat. How do we emphasize the interconnectedness of this all? And I don't know that from my perspective, I feel pretty discouraged when it comes to that question at this moment in time. If we can't see it in a case like COVID-19, I felt stymied in how you from either a historical or an ethical or just an epidemiological perspective, make that case in a way that people can understand.
If I could follow on that, is that all right, Jeremy? So I just wanted to say that back in 1949, Linus Pauling identifies sickle cell as the first quote unquote molecular disease, and in the case of sort of being very clear on who evaluates the impact of technological innovations, for many molecular biologists, that was the major accomplishment. And the fact that there hasn't been a really effective therapy based on that knowledge is sort of something that they regard as not necessarily the most important thing. And one of my colleagues has gotten into various sparring matches when he sort of had pointed out decades ago that, well, what was the impact of that knowledge? And so, to Karen's point, I think this also gets back into the activism of the Panthers and other types of patient advocacy organizations. You see, one of the big moments for sickle cell anemia historically was not just the efforts of the Panthers, but like the lobbying that went into getting federal support for types of, some types of palliative or useful care. And certainly if we have a major, CRISPR-based therapy, it's going to be quite pricey. And the next question is going to be, how do we pay for it and make sure that people don't suffer even more from a disease, but also from the knowledge that there actually is a treatment there. And this is sort of where around different diseases, I think that is a new development at the end of the 20th century of, around ACT UP and AIDS or around breast cancer, around other diseases where people do come together and they assert that they have a common interest and they are both active in setting policy, but also in some ways building knowledge and contributing to research and trying to fashion terms that might lead to a good outcome, not only for knowledge, but also for sort of the members of the community who sort of face the risk of that disease the most.
Can I ask you something, Robert? People say this sometimes, and I heard it in your comments. Do you really think it's an obstacle? How do we pay for the technology? It seems to me that we just paid for extremely expensive war in Afghanistan. We threw out trillions of dollars last year and this year in coronavirus relief. We seem to be able to print money when we want to. And so it seems to me that the issue is, how do we generate the desire to pay for it more so than how do we pay for it, if that's a fair add-on?
Oh yeah, by how do we pay for it, it's a question of governance and participation. It's not a question of it being unaffordable in an absolute sense, but nonetheless, that's been depending if from somebody who works in traditional bioethics, where these questions of health policy and access can be pushed to the periphery, that is sort of going to be, in my mind, an integral question to discussing the impact of, a genomic technology or therapy is access has to be part of the conversation alongside sort of the innovation. And I think that very often the access part can be left out of the innovation conversations, or there's an assumption that innovation will necessarily entail resolving access. And I think it's certainly possible, but it's not always easy.
So what do you see the access hurdles to be? Just basically the political will in the Senate or something, or could be. I mean, that could be.
I mean, I think anyone who has had to deal with insurance billing for getting, new treatments approved, the mass amount of fencing it took around getting insurance to cover pre-existing conditions. So you can imagine this was one of the concerns back to the 90s, that genetic predisposition would be considered something that an insurance company wasn't responsible for paying for, and there was a legislative remedy to that. So once again, these are problems that have resolutions, and certainly in the past, special funds have been set up to pay for particular types of treatment. I'm thinking of dialysis in the 1970s, and there are others that could be considered. And of course, in the background of this is all what types of healthcare delivery should we pursue. But I think that's a big part of understanding the beneficial impact that advances in scientific knowledge can have for the population as a whole. And depending on what types of people you hang out with, you either hear about that more or less. And I just want to make sure that it's heard here.
So is there literature on or data on the extent to which Americans think that they aren't responsible for the genetic diseases of others? That's just, I feel bad for you. It's a bad hand you were dealt, but it's not a social sort of caused thing or something like that. If it's genetic, then you got to pay for that yourself.
Yeah, Jeremy, I'm happy to respond, but I don't want to. This is a rabbit. So I think I think this comes back to that question of how community is defined, and the way that that genetic information is part of the way that people understand their community. And so in the case of cancer research and cancer vaccine development, there is, back to the 70s, because it's all structured within the National Cancer Institute, the National Institutes of Health, a sense that in that case, the needs of Americans come first. And you have various people working in molecular biology and advising the National Cancer Institute saying the link between hepatitis B and liver cancer, which is something that could have been addressed through vaccination. That's not a priority for the United States because it's not happening in our borders. You certainly have assumptions or framings of different types of disease that are, one of the reasons the United States has a long, struggles to deal with something like liver cancer for a long time is because it's not a sympathetic population, whereas the types of cancer research we first invest in follow sympathetic communities, such as, say, children. If you think about sort of early leukemia research in the March of Dimes. And I think that's, recurs in terms of the types of communities that are seen as being at risk, how they're lumped together. And then separately from that, there's these broader questions as a sort of in terms of how billing works, how responsibility is allocated, that are important for thinking about how treatment is distributed. And all the more so when you have a treatment, for example, that has yet to be fully approved by, say, the FDA, and how that filters through the infrastructure of healthcare.
So I want to take us. I think these are essential questions for thinking about the fundamental ethics and access to an emerging technology. And I think oftentimes get to this problem of the promissory benefit, which does not necessarily translate until many other forms of deservingness in a political calculus actually come through. And we see this both within the domestic context and also in the things we will and won't frame in the United States as acceptable sites of global public health investment. I want to take one more question before opening up to the general audience, because I know there are a lot of questions out there. And I want to encourage those of you in the audience, if you do have a question, please use the Q&A function to put it forward. And we'll start getting to them almost immediately. The first question I had, the last question I want to ask, though, it starts with Amy, but it really goes to all of you. And it has to do with how we understand what I think you labeled earlier as the sort of, agnostic quality of technologies of surveillance, right? That they can be, you mentioned in the earlier case study of your earlier work in the emerging HIV/AIDS epidemic, how the problem of public health response was seen as great as the problem of the disease itself. And yet in some of the later examples you're giving, especially in terms of breast cancer, how the will to surveillance is coming from many populations themselves. And this was reflected very much in Quayshawn's comments about the Black Panthers and sickle cell screenings as a crucial aspect of some of the health wing of the Black Panther Party. And I'd like to ask you really here, if we think of surveillance, a tool that is often used to enhance and justify existing forms of nativism, racism, and xenophobia, but also has the potential for countering these very same elements, how do you balance the way in which genomics as an emerging platform is a recapitulation of the same problems that you've seen in 19th and 20th century public health surveillance measures versus the way that it offers fundamentally new challenges, but also new potentials?
So I'm gonna to dance around that question a little bit, just because my work has really focused on infectious diseases and not genomics. But I think I think the engagement of populations in the politics of public health is a key factor to determining how technology is used for what people see their benefit or against them. So, one of the things that happens in the context of breast cancer, the Massachusetts legislature, I think it's in the 1990s, decides that it wants to make, you have to consent to be part of the state cancer registry. And it was women with breast cancer who came out very strongly and said, that is not in our interests, because what you're going to end up doing is you're not going to get 100% attainment of the population of women with breast cancer. And it's really vital for all of our interests. And this goes back to these notions of community responsibility, for all of our interests to be there. We owe it to each other to be part of this registry. And if you begin to require consent, you're going to undermine the kind of popular power of the registry to produce the information and the knowledge that our community is demanding and wanting. But I think one of the key aspects of there that women themselves were part of this grassroots movement, and Bernie Sanders was key to it nationally, and helping to get federal funds for cancer, and this, the same is true of HIV/AIDS, not on the surveillance front so much, but it is the gay community that ultimately, it's fractures within that group that ultimately really paved the way, for instance, in New York State, for HIV surveillance, because as there's Ryan White funding, as there's highly effective antiretroviral therapy, and there is a concrete benefit from the act of counting people and counting resources, individuals and affected groups begin to diverge in what they think is best for that group. But I think it's what we term the democratization of privacy and the politics of public health that really happens in this era in which you have groups like the Black Panthers, the Young Lords, feminists, the women's rights movement, the health and human rights movement, where where it becomes impossible not to engage in democratic decision making about surveillance without the participation of groups. And I think it's when groups have not had a voice, and I think this is one of the things that troubles me about the COVID response, when they're not part of the politics of public health. That's when I begin to worry that the things we're going to do are not going to be in the interest of those groups, and they need to be at the table, and they need to be driving the agenda and the narrative.
I'll throw out something that's new. Somebody wrote in the Q&A part, Stuart Ray, I believe, about the potential to worsen disparities between groups based on the very technologies that were produced. That we're producing. So the way I'm thinking about this is like algorithmic bias.
Quick, 1 second. I don't want to interrupt you, but I feel like if we're going to bring Stuart Ray's question, and I don't think others can necessarily read it, so we should probably read the Q&A to the crowd. Do you mind if we do that really quickly? Because I want to hear your response, but I also want everyone to get to hear it So Stuart Ray had been asking, given the way technology proliferates, it seems to me that the genomic sequencing, host and microbe, will happen, and the major danger is disparity baked into intelligent systems that are opaque to inspection of the population representation, to criteria for training, assessment, etc. That tech gets cheap, whereas systemic biases survive and proliferate into new tech. So I very much want to hear your response, Quayshawn. I just want to make sure the whole audience could hear the question.
Yeah, so this is a new area of both. It's like intersecting computer science and philosophy, algorithmic bias and ethics. Basically, you think that you can do things better, and in a lot of ways you can with computer technology. But then you can, reproduce systematic biases with that technology and even make them worse, right? And one way in which the situation could actually be worse is that we think that it's not worse, right? And so we don't even have the protections to protect ourselves against the biases that are in there because we think it's a computer, and computers don't make mistakes, but they do. And they do because they're created, computer technology created by us. So, I mean, there's very technical problems there that are being worked on by people with the intersection of ethics and learning theory and computer science in general. But we see it in the bringing in computers in giving out mortgage loans in the mortgage loan sector. We see it in criminology when we brought computer technology into trying to figure out who committed a crime or something and have police forces use it. There's no reason to think that we shouldn't expect the same problems in genomic science when we get pretty heavy reliance on computers.
Thanks. Other thoughts from other panelists in this question? So I'm going to move on to another question from Karen Meager, saying, wants the panel as a whole to discuss how both genetic and population health data reveal how the health of individuals is interdependent. How can bioethics help and prepare scientists and policymakers for political and social discomfort with the denial of human interconnectedness? And I'm thinking how this works at this intersection of genomics and infectious disease.
I can say something from slightly left field, but it goes back to, I've just been reading and thinking about sort of the discussions of the microbiome and the virome that have been occurring in public health. And that, of course, is the type of discussion that having genomic data is very important for. And one of the suggestions that's being made by people working there is that, for example, when one person in a household takes an antibiotic, almost everybody is taking it indirectly in terms of the types of bacterial populations that emerge on their skin, for example. So it could be that these types of genomic efforts provide ways of providing some type of biological substrate to the argument that we're more connected to each other than sort of the individual case-by-case basis that we might be encouraged to sort of take disease as. But that's, as I said, sort of that's a non-credit thing, but that's one of the, once again, in Brown Kendall Square today, where there's a huge amount of interest in sort of the various populations that live in and around individuals and the connections that they maintain to other members of the community.
Thanks for that, Robin. So there's a question from John Noel Viana asking, is there a difference using race and ethnicity in determining and reporting the prevalence of infectious and non-communicable diseases in communities? Also, how is race determined for mixed race individuals? Is it based on how people self-identify?
I guess I'm up. So, I mean, as I said earlier, I'm a pluralist. I don't think that there's a single correct answer to these questions. There's different ways of thinking about mixed raceness. For example, having different ancestries, being treated differently, seeing yourself as being different, being treated differently throughout your life, being treated differently at the same time by different people. But I think what's important to focus on is how which race variable we use in which medical intervention or medical research, or even medical education, as opposed to just having crisp answers for particular things.
And I would just add on to the first half of that question. I think from the perspective of stigmatization, and particularly in this country, and the weight that we put on notions of individual responsibility, and the weight we put on the ways in which we assign responsibility for disease, whether it's infectious, whether it's chronic, to individual behavior and choice. So I think the impact is the same in terms of reporting. You have the same responsibilities to think through the pathways through which it works. And I think too, you can take an example, and I think we can't think of these as such. There are blurry boundaries between infectious disease and chronic disease, right, too. So you can't understand patterns of disparities in COVID morbidity and mortality without also understanding disparities in chronic diseases. So diabetes, obesity, cancer, these are all some of the factors that predispose individuals for far worse outcomes in terms of the severity of illness and death, when it comes to infectious diseases, just like it is in terms of access to education. So I think that these are all bound up in the same bundle of how historically we haven't grappled, and this is going back to Karen's question about how do you create a sense of collective interdependence that we just, at least in this country, it's an idea we've struggled with for centuries, and struggled with even more profoundly since the 1970s and 1980s.
So we have a clarification from John Noviana that it was questions of using race versus ethnicity as different kinds of kinds. I think each of them have a risk of being treated sort of in a kind of a simple being biologicized, even as they are declared socially through equations that happen between ancestry group and the way that race is used colloquially and in everyday life as a dynamic thing in American society. But I'm happy to open that up, especially to the panel. If this ties into I think a related question by Timothy Thomas, asking that the NIH is pushing that funding for research is contingent on willingness to share data, and that there's lots of concerns among indigenous groups in the United States and over the potential for intentional and unintentional misuse, even with safeguards at NIH as they have in place. And so this question of how one thinks about race, ethnicity, sharing and not sharing, and the concerns over representation and misuse of these data pools as sort of static biological kinds rather than as the dynamic and interpolated entities that we know them to be.
Oh, this is a hard one. I would say folks who are interested in that probably should check out Kim Tallbear's book, Native American DNA. She outlines about 8 different sort of concerns that indigenous populations to the Americas have with, working with the medical geneticists and so forth. Some of them are really, it's really, you have to get into like political philosophy to really see how to wrestle with this. For example, one thing she was talking about in the book is, look, yes, getting genomic information of certain indigenous groups can be very helpful to advance medical sort of insight and so forth. But they have their own, sometimes they have their own creation stories, right? That are linked to their religious beliefs. And they might not want to have their information used in a certain, or genomic information used in a certain way that potentially undermines those religious beliefs, right? Now, your standard American geneticist is going to be evolutionist and is not going to respect the creation beliefs of any indigenous peoples. So you have had some butt-ins with that. You've also had other things that are more having to do with like more obviously dastardly things. But respecting religious autonomy and other autonomies seems to be a central theme of Talbert's book. Sovereignty, another thing she was interested in is sovereignty to determine who's a member of the tribe, member of the nation. Concern is, well, you know, they get all this genomic information and then they determine who's really Navajo, right? And it takes the power out of our hands. Maybe that's a concern. Undermining claims about them being on this land. What if they use the genomic information to undermine them being the first people in what is now considered Nevada or something? It's like, well, if you're not the first people, why should we give you first American rights, right? So all these things have to do with autonomy and sovereignty. Very tough issues, but I think that's a good place to start that book.
See, I'm sorry, should we move on? I wanted this one Nature paper from 2008 I want to pick on, which was sort of right when a iteration of sort of genome-wide association studies was taking place, and they did this a mapping in both the genomic but also physical sense of Europe, in which they seemed to sort of find these clusters of specific, SNPs, ISMP sequences that correlated with, like, the German, the geographically, there's a Germany area and an England area and a France area, and it seemed very compelling that there's like not even just a racial differentiation, but like this ethno-nationalist differentiation. But it's one of these cases where it's like, when people are moving across different disciplines, it pays to read the methods and the footnotes. And if you read it, they discuss, oh, like we took all these samples, but like these 4 people were from China in our England sample, and we know they're not English, so we took them out. And like, these other people in France were from Senegal, so we took them out because they're not appropriately French. And so you see this at the level of the practice of how data is collected and used, which is sort of once again, it's not a do or not do, but how you do question. Those are the types of things that we need to be alert to. And alongside Professor Spencer's discussion of Talbert's work, one of the other, I think, keywords there is how researchers think about property. And I think that sometimes exists in tension with the commitment to, say, open access or having a commons for research, because a number of people who have looked at, and Kim Talbert is a very prominent example, other people have looked at, say, bioprospecting and related areas, have emphasized that the creation of a commons in certain areas is itself an act of appropriation. And one of the things that passed through my mind thinking about it is like the collecting like microbiological things that you shed I think is sort of considered okay because it's sort of a type, like the assumption I think we're shedding it, and therefore it's a type, would be treated as a type of trash. But is that necessarily how this is, information should be treated as a form of collection? Because we've seen issues with that around cell banking before, in terms of who gets to claim ownership over things that are emanated from their body, especially if you can imagine someone who's very sick with a particular strain of a virus, having that sort of removed from them and used without credit. There's a whole set of issues there that might be worth considering further as well.
And the other dimension I would add into this is the questions that we've historically asked around, well, are there things that are legitimate in the realm of public health surveillance, data that's collected by health departments, and when you have mandatory reporting, you're essentially conscripting people into social inquiry. In public health, there's historically been a reluctance to call it research. But on paper it looks the same, but the purpose is different, and accountability is different when it's health departments versus researchers. But it's been a contested area for a long time, and I think it's worth asking those questions. Is research somehow is public health surveillance, when you're doing something in the name of people as a whole? Is there a greater imperative to participate, to share data, to link data? That's one of the challenges that we struggle with in public health, is that we have siloed data in states. There was, for a long period of time, the HIV registry and the TB registry in New York State couldn't be linked. Now that's been changed, but that was a tremendous problem in the context of the AIDS epidemic, when you couldn't determine if somebody had both HIV infection and tuberculosis. So that's just another dimension to think about as we consider these problems. But I think, given the ways public health systems are funded, genetic and genomic data are probably unlikely to reside there, beyond the few places we've got some genomic surveillance for COVID and some other diseases.
I like this brings us to a related question from the audience, Matt, and I also want to point out, so Amy, the points that you're bringing in right now about withholding of genomic data and withholding of infectious disease samples have both been very recent issues emerging in questions of sovereignty, difference, inclusion, exclusion in public health research, right? Which links genomics and infectious disease thematically, even if it's not in that bridge itself. There's a question from Gail Geller asking the panel in general to comment a bit more about the relationship between surveillance and stigma in particular at the intersection of genomics and infectious disease. So what if we were to discover a genetic variant associated with increased severity of COVID? And there's indeed quite a bit of work going on in this area right now. How would subsequent genetic surveillance programs be received by people, and what aspect of stigma might be perceived or experienced in that process? How do you build that into the way that you begin to assess the technology in the beginning?
I mean, that's an important question, and it's one I can tell you how we struggled with it a little bit on our own campus when we began doing genomic sequencing, and in part, the way we answered it, we couldn't do real-time sequencing, and we still can't. So knowing we learned variants far after it was too late to intervene differently in any ways, but those were the questions we asked ourselves. So if you have a more lethal, more transmissible variant, and you knew somebody had it, I mean, the question is, do you have a different obligation to act in a more robust, a more muscular fashion than otherwise? And then what happens if those variants begin to behave as we would predict, given racism in the United States? And I noticed Graham Mooney put in an article about by Braveman and Dominguez, abandoned race, focus on racism. So we could certainly expect that places that experience structural racism or structural discrimination in some fashion, you would see more lethal variants being concentrated, and that would be very troubling and very, very problematic, given a long history in this country of wanting to. If you look at the way African Americans were responded to in the context of Sam Roberts' work on TB in Baltimore, and Graham Mooney's work on that front too, and the way segregation became really a fundamental strategy for public health response. You see the same thing in San Francisco with Chinese population. So I think it's a profoundly troubling question, and one that we have grappled with and not grappled with well, and that we need to be prepared to think through before we have those variants.
Let me jump in and roll back with I feel like this is another sort of way of asking about racist attitudes and things like that. I mean, stigma is more general, but so when I brought up the Brian Donovan research, I only told you half the research. Identifying the problem was only part of the beauty of what he found. It turns out that even though you can increase the racist attitudes of individuals who aren't well educated in classical genetics by just mentioning or couching genomic disease information in racial terms, you can also get rid of all of that if people are appropriately educated in classical genetics. So I mean, there was no effect for people who were educated in classical genetics. We're all educators. We're dancing around the issue. If you don't want people to develop these sort of stigmas, we need to improve the way that we educate people in this country. These are not effects that you find in statistically significant ways when people are educated about the relevant science.
Quayshawn, just to interrupt here, that's very appealing, right? And I think it's going to appeal to a lot of the people in this audience, many of whom are educators and are interested in education as a solution, right? But is the study you're talking about, is it cross-sectional or is it longitudinal? In other words, did it demonstrate that actually an educational intervention in classical Mendelian genetics helps to insulate against racist beliefs when focused, or does it just show that these two different populations?
These different populations, the people who were susceptible to developing the stigma were people who, so of course you've got to do follow-up studies to see if the intervention is causal or correlational, but I mean, it would seem like there are other options we can go instead of oh well, we just can't ever talk about this stuff in the same sentence. At least we should explore the extent to which we can educate our way out of developing these stigmas.
So I'd like to bring in one question from the audience that speaks to this in inverse as well, and hear how everyone responds to it. This is from Larry Brody, asking that, relevant to the measures of factors of disease, it has been proposed that we ignore race or don't even ask when carrying out biomedical research and only collect data on the physical and social environment, all of it, and genomic data. So that, what does the panel think of this approach? Assume that the issue related to algorithmic bias has been solved before we crunch the numbers.
So that would be a lovely world that is being imagined. I'm skeptical that one could pull that off in the world that we actually live in and not reduce the quality of the science coming out at the other end. I mean, one sort of implication of that suggestion would be let's just not concern ourselves with race when we sample people, when we're doing clinical studies that are testing the effectiveness of a drug or something like that. And lo and behold, that's what we usually do. There's been studies that show that the racial diversity of the samples of the clinical trials that then get considered by the FDA for whatever drug you're trying to design, usually extremely underpowered, usually almost entirely non-Hispanic white samples. And usually it doesn't make a difference, but sometimes it does. In fact, when everyone was talking about COVID-19 this year, I was following the results of a lawsuit that the former Attorney General of the state of Hawaii filed against two pharmaceutical companies that developed it was a clopidogrel. It was basically a blood thinner that improved your chances of not getting heart attack or stroke. And it turns out that there were some alleles that if you had them, you were less inclined to metabolize this drug well, right? And if you were homozygous for those alleles, you were metabolizing it at all. Now, it turned out that the Americans who tended to not have this allele in proportion, so most people have this allele, but of the people who tend not to have it are Pacific Islanders. A huge chunk of our Pacific Islanders live in the state of Hawaii. So when they wrote out this drug and it was widely prescribed by physicians in Hawaii, Pacific Islanders were still dying. It didn't affect their sort of the rate at which people were surviving heart attacks, even though they were getting this drug. Now, the pharmaceutical companies knew about these alleles, knew about the link to Pacific Islanders, and they got a warning from the FDA. They had to change the language on their like the sort of the package insert. They didn't do it, and it's kept business as usual, right? Race blind, business as usual, pumping out these drugs. Doctors were prescribing them. Pacific Islanders were dying at a disproportionately higher rate, even though they were taking these drugs. So what I'm worried about is, if we get this sort of one size fits all medicine, what's going to be the effect on racial minorities who aren't going to show up in these samples? And, the Attorney General of Hawaii sued these companies, and they won hundreds of millions of dollars from these companies. You can look it up on Google later. It was a big, huge lawsuit. Nobody was talking about it, but I thought it was very relevant because I was looking at the racial sampling in the COVID-19 studies the year before, and there was some concerns there. The NIH stepped in and slowed down Moderna's sampling for that reason. Nobody was slowing down Pfizer. So I think we're not there yet. It would be great if we were there, but I'm still skeptical about that kind of approach right now.
So so we have a few more questions from the audience. I know we're running low on time here. One comment I wanted to just add here is this observation that Jonathan Kahn makes in his book on race and pharmaceuticals and vital race in a bottle, that you use this notion of the politics of the meantime, that race is oftentimes used as a shorthand for genomics, and the concept is, well, once we get to genomics, then we won't need to use race anymore. But until we get to widespread availability of genomic technologies, we need to use race for reasons like prevalence of sickle cell anemia, things that we would otherwise ignore that really have to do with using race as a proxy for ancestry. And yet it seems that a lot of what we've been talking about today is that once we do begin to have genomic measures available, it's really heightening and hardening biological notions of race rather than the other way around. Like race doesn't become less relevant now that once genomics becomes available, it perhaps becomes accentuated. Now, I don't have an answer to that right now. I want to turn to one question from Brian Hutler, and this may be the last one we have time for, saying, I'm struggling with a question that Quayshawn raised about how we can equitably make use of advances in genetic technology and medicine, e.g. by not overlooking potential benefits to members of different ancestry groups without provoking racism or providing cover for racist policies. If this is purely a political problem, then should we try to slow down genetic research until our politics can catch up? And Stuart Ray in the side column has just, in chat, has just provided evidence that this is not happening at all, that if anything, what's been happening with genomics in the case of the COVID pandemic is just accelerating on its own and propelling itself incredibly fast, reflecting his earlier comment about tech becoming available faster than our work to contextualize. But Brian wants to ask if we can't slow it down, are there strategies we can develop from within bioethics and medicine prior to finding social and political solutions to racism? Now, it's been a long evening. You've all been speaking for 2 hours, and that question may be something that we actually end on as an aspirational goal. There are still going to be some more elements of this particular Levi Symposium to come.
Well, I'll add one thing, and it comes from work that we've been doing here at OSU, looking at the sort of the absence of ethicists on university response panels in health departments. And I think one solution is to make integration of ethics in a sustained and robust way part of the way we practice research, not just looking at these questions in an IRB, but who do you have on your team? Who do you have on your decision support team, your decision-making team, whether that's on a research team or particularly within government, that really recognizes this is as important as the science.
I would, sorry, please.
I was just going to second the emphasis on digging deeper into the ethics, and in particular, my PhD student Ian Peebles, he's working on this issue in his dissertation. So if his work is of any use, I think it would be good to check it out. But these are tough issues, and you can't. Scientists aren't going to be able to solve this on their own. Bioethicists are definitely going to be needed on the ground.
Yeah, I was just going to add that sort of like trying to slow down an oil tanker or something. Like these are very difficult adjustments to make in the moment, and that's all the more reason to sort of think very deliberately about the institutions and changes we need to make now in order to be ready for what may come. And that's why I spend a lot of time sort of talking about governance of science and the institutions that science operates within, because those are the things that really sort of can direct the technology to malign or beneficial ends, even if we don't yet know what the contours of that exact technology may be.
Well, I want to thank you all for being able to loop back on such a profound question with such concise and meaningful answers, and for taking part in this panel, which as we think about these intersections of susceptibility, surveillance, and stigma at the intersection of genomic technologies used for infectious disease, we find ourselves coming back on just some of the most profound questions of how we govern our resources and how we manage deep historical and structural burdens that are freighted and weighed in the health and illness of bodies in American society and around the world today. We've had a number of participants sticking with us through this from around the world, and I want to thank all of you who took part of this, and really please join me in thanking the panelists with, again, what is always an awkward and silent but no less heartfelt applause for your part in this discussion today. So thank you very much. And rather than just hearing me clap, I will formally end this meeting and thank everyone, and look forward to continuing this conversation in different forms as this moves forward.
Thank you. Good night.